Hi, my name is Jennifer Hamilton. I will be presenting our group's presentation about rapid cycle PDSAs for quality improvement during the initial period of the COVID-19 pandemic in a cystic fibrosis clinic. Here is our poster, and we hope you have an opportunity to review it at your leisure. The COVID-19 pandemic has necessitated novel practices to ensure that children with cystic fibrosis, regardless of where they live, get the care they need. Our catchment area is quite large, including Utah, Eastern Idaho, parts of Nevada, and Wyoming. When we looked at our patient population, 34% of our patients live in rural zip codes. And what has been interesting is that patients require surveillance of pulmonary pathogens via oral pharyngeal swab cultures or expectorated sputum every 3 months. Historically, this has been done with in-person clinics, but due to the pandemic, we've had to shift this practice. Our methods for changing practice included multiple PDSA cycles to implement practice change in a rapid and systematic manner while allowing us to observe if the effects of these changes had the desired impact. We obtain cultures via a couple different methods, but for the purposes of this presentation, we're going to focus on the self and caregiver collected at home with mailed directions and supplies. Here is our graphic of our PDSA cycles. We in cycle 2, 4, 5, and 6 focused on these mailed cultures. With the first cycle mailing to patients who lived close to an affiliated center where the lab could process the specimen as we desired. Cycle 4, the move to patients who did not live within a reasonable distance in an affiliated center and required more support from our team and coordination in obtaining those cultures and setting them to labs that could process them as we needed. Cycle 5, we looked at the cost of shipping and adjusted our practice. In cycle 6, we looked at our return rates and decided they were not as we wished. So we contacted families and encouraged them to obtain the cultures and send them to the appropriate lab. This is a graphic looking at our culture obtainment. So gray is the number of curbside cultures we obtained. Blue is the mailed cultures and orange is the return cultures. As you can see, we initially mailed more cultures than were returned, and then we had more returned over time. The overall rate of cultures obtained declined in July as we resumed more in-person visits. In the 4-month period, we obtained 133 cultures. Half of them were done via self or caregiver collected in the patient's home. 120 cultures were mailed and about half were returned. Most of the patients lived within a reasonable distance of an affiliated facility, and we allowed patients to determine what an affiliated facility was in within a reasonable distance. When we compared the patients who lived further from an affiliated center and had to use a non-affiliated lab, the return rates for both were similar, and it was a much smaller group that used a non-affiliated lab or facility. This is our shipping cost. As you can see, initially used a private shipping company, and the average cost per item was $18.74, which was not sustainable and quite expensive. When we switched to the US Postal Service, our average cost per item was $3.80, which was significantly less and allowed for more sustainability. Overall, these PDA cycles allowed us to make rapid changes to meet the need of our patients and allow for similar access to care for those who lived rural versus non-rural. And we will continue to use quality improvement projects to meet the needs of our rural and underserved patients during this pandemic and after.